everyone.
That's the only one. I would have circled back and visited them.
Pediatric grand rounds today. Remind you to fill out your evaluation forms, which are all online. It's right part of your invitation. We appreciate you joining us this morning. Today it's my pleasure to introduce Gregory Robinson, Ph.D. Greg Robinson grew up in North Carolina and attended the University of North Carolina at Chapel Hill for his undergraduate studies. He went on to the University of Georgia to complete his Ph.D. in counseling psychology. He completed an internship in psychology at the Central Texas Veterans Healthcare System prior to doing his residency back here at Lewis Gale Clinic in Salem, Virginia. He's worked with children, adolescents, and adults in the general practice at Lewis Gale for 5 years prior to his move to Carilion in 2005. He's been working in the Child Development Clinic for 17 years. He conducts cognitive, achievement, psychological, and functional assessment on children with developmental disabilities, including autism spectrum, intellectual disabilities, specific learning disorders, and ADHD. He conducts psychological consultations on children and adolescents who are hospitalized in the inpatient and intensive care unit as well. Dr. Robinson has experience utilizing cognitive behavioral therapy for the treatment of OCD and anxiety disorders. In his free time, he enjoys the beauty of the mountains of Roanoke. Please join me in welcoming Dr. Greg Robinson.
Thank you very much. And good morning, Roanoke. All right. Ooh, morning. Okay, y'all. Let's see if I can get the buttons to work here. Okay, as far as I know, I don't have any financial relationships or non-financial. I'm not going to be talking about drugs, and I don't have any stock interest in the testing companies that I talk about. This is kind of an introduction to the clinic. I mean, I've been here almost 18 years in January. And in the beginning, it was one developmental pediatrician, myself, an education consultant who didn't do testing, and a social worker, and then a nurse. And so now, goodness gracious, we have a developmental pediatrician, 3 nurse practitioners, a psychiatrist, and a ADHD expert pediatrician, Dr. Harkoff, who also works with kids with autism and other assessments as well. So it's quite large. We did have a speech therapist and an OT back in the day. Now Missy is with us, and she can do some of the autism testing, which is super helpful. And Tara Mitchell and Lori, they aren't technically in the clinic, but sometimes they assist with some assessments as well. So, all right. So populations that I serve, this is pretty much what I do. I work with kids with autism, global developmental delay, cognitive delays, intellectual disabilities, specific learning disorder. Age range, typically 4 to 17. In reality, it's probably more like 6 to 14. Although I had a 17-year-old yesterday for ASD. I get all the older kids for intakes and evaluations, and that was an interesting one for sure. So the role is primarily to do psychological testing. When I was hired, they were like, this is what you'll be doing. So that's really what my role is. But I do the initial consultations and evaluations on kids that are probably, I think it's typically 8 and up, usually is the ones that I see. Of course, I do the interactive feedback sessions. I do those consultations at the hospital sometimes. That was added in 2014. They used to do counseling for OCD, but honestly, we have so many referrals coming in. That's not, my role was really to do testing, so that's on hold. All right, now to the test versus assessment. What is a psychological test? An objective, standardized measure of a sample of behavior. Now, having said that, the test I'll talk about the most is ADOS, which is not really objective or standardized whatsoever, but most of the other ones are. You have tasks or problems that you have to solve. They need to be valid and reliable. Valid means that you're testing the concept that you're supposed to be testing. And reliable means if you test it like 10 times, it should be consistent. You should get the same results. So they use a lot of statistics in the development of these tests, and they do a lot of administrations to make sure the tests are valid and reliable. Typically, you involve comparing a person to a normative sample. We'll talk about that more later. Assessment's more what we do here. That's where we integrate information from a lot of sources. We always try to get collateral information, definitely from parents and caregivers, and from teachers. We used to routinely, our IC coordinators could get that in advance, but we Things have changed recently, but we still give out those questionnaires and try to get teacher information as much as we can. And it depends on the situation. It can include tests of ability, intelligence, behavior. The testing is just one data source, and the type of testing obviously depends on the question. We will talk about that. So these are the things that we test for. Autistic spectrum disorder, ID, it's a little repetitive than the other slide. Cognitive testing, cognitive and achievement testing. ADHD testing, I don't do it strictly as a standalone referral, but I will do it as a part of testing for autism or specific learning disorder. I don't do strictly ADHD. Dr. Hartkoff does that for the children under age 10. Is there a question?
No, I'm just trying to find.
Oh, okay. Cool. This slide is just cool. This is from the second developmental nutrition I work with. This is from Dr. Corcoran, and I always thought it was a cool slide. But it does look at the streams that when they're looking at the younger kids, they're always evaluating these domains: language, problem solving, social, adaptive, and motor. And when they send to me, I'm looking really at the two in the middle, the problem solving and the social adaptive. So, all right, so just to give like an idea, this is a heavy text slide, but kind of an example, and you would never do all of, well, not never, occasionally you might do all of this with a kid, but these are the possible assessment domains for autistic spectrum disorder. And really the first is the developmental history. I mean, that's psychiatry's major tool, and honestly, it's a huge tool for us. I mean, a test is just one piece of data. You really need to understand the context of the behavior and the history of the child. We get a lot of kids that have huge trauma histories that are referred for autism. Occasionally there might be one, but a lot of times there's other stuff that can account for the behavior that we see. I usually interview, for autism, I've got a 3-page semi-structured interview that I use. It's something Dr. Corcoran and I developed way back when. And so that's really important. 2 is the ADOS, the Autism Diagnostic Observations Schedule, which I'll talk about more. That's a cool thing that we do. The coolness of it is you actually get to observe the kid and you get to prompt and pull for certain behaviors. That's a nice one. That's a good one. Cognitive and behavior assessment, that would be IQ. Adaptive behavior, that could be like the behavior rating scales. Speech, language, and communication. I feel like we used to refer perhaps more, I don't know, but I still send to Missy sometimes when I get the older kids who really have not had any speech therapy. And then motor skills and sensory processing we send to Tiffany Kuiper. Sometimes we'll make referrals to psychiatry. We do have Felicity Adams, I think it's twice a month, I believe, for half a day. And she gets some of the kids that have things like comorbid mood, is it 4 times, my bad. So that's awesome, that's more than I thought. And she gets some of the kids that have comorbid mood disorders and behavior, challenging to test and pharmacologically complicated interventions. So genetics occasionally, usually I don't refer to genetics, but I have maybe a handful of times. Neurology and then gastroenterology. A lot of our kids, we have to refer to gastro because they got backed up bowels and stuff like that. All right. Now, doing this just because I'm a nerd, and maybe make it interesting. I don't know, make this a tad bit interesting. I think the history is kind of cool before I go into the actual test for autism. Initially, this guy, I can't say it, I think it's Bleuler, said the term autism. Leo Kanner is really the guy that was known for this back at Johns Hopkins, and he observed 11 kids. That's him on the bottom left there. He's the one who used the term extreme autistic aloneness. So that's where that came from, and really started the key initial category with the language, social skills deficits, and insistence in sameness and following routine. That's his definition. I'm not going to read that, but that's where the first extreme autistic aloneness came from. But I don't know why the number 12 is in the bottom. Whoops. Okay. I normally talk about OCD, so I'll notice those kind of things. All right. So Hans Ansberger, most of y'all have heard of him. And he developed he was looking at different kids. He was looking at the high-functioning kids. It's not like it's a totally different animal, although eventually in 1994, there was a specific diagnosis called Asperger's. But basically, he was working with the kids that had normal IQs. We see a lot of kids like this. These are the kids I tend to see more often than not. Poor nonverbal communication. They struggle with empathy with peers, all-encompassing focus on a single topic, physically clumsy, And he's the one who coined the term little professors, which those are some of my favorite. I love them. I like to learn about things. I like to hear some of the kids, although honestly, Minecraft and Roblox, I think I've heard enough. So anyway, I'm sure most of y'all have heard of Asperger's. Just a cool picture. I thought that was cool. I found this a long time ago, and that's him on the second from the left, I believe. So he was in Vienna. Pretty cool. Now, Rudder, 1968. This guy, and he just passed last year, major figure. I mean, he was really the pivotal figure in the development of autism, and really, he helped differentiate autism from childhood schizophrenia. It was confused a lot in the 40s and the 60s. Just a few other history things, and we'll get to the testing. I just think it's interesting. I don't know. Bruno Bettelheim talked about the refrigerator mom theory, that it was basically frigid mothers that caused kids to be autistic. Of course, we know parenting does not cause autism. Now, being a frigid parent would not be helpful, but not cause it. Rimland is the first one who started to change it into the neurodevelopmental area. And then Rudder, 1968, year I was born. I think it was after the Summer of Love in 67. He's the one who differentiated autism from schizophrenia. He really took out the absence of delusions, hallucinations, stable course. And then he's really one pivotal in our assessments today. He's the first author of the ADI-R, which is an extensive, long, extremely painful interview that we really don't use because it's mainly used for research, but it's excellent. I use the social communication questionnaire, which pulls 40 items, which are some of the key items from the interview. And then he's the second author of the original Autism Diagnostic Autism Diagnostic Observation Schedule from 2001. And we're in the second revision now. Just the DSM history, I'll go quick. 1980 when it was first put in there. 87, it was changed to autism from infantile autism. Asperger's, they allowed him in 1994. Text revision in 2000. I don't think a whole lot happened there, but in 2013, a ton happened. We got rid of autism. We got rid of Asperger's. They got the Heisman, childhood disintegrative disorder, and PDD-NOS. And so now they've all been put into autistic spectrum disorder. So that's kind of where we're at now. Lord, I won't go through all these too much, but the only reason I put these in there, if there's some pediatricians that are not as familiar with this, I get a lot of referrals where kids are strictly oppositional, defiant, they're being mean, they're throwing cats out in the road, or they're hurting people or setting fires, and they think, well, maybe it's autism. And occasionally, not saying that couldn't possibly happen, but a lot of times they're behavior things. And so, with autism, it's really more of a social impairing kind of disorder. That's really what it is. And it is hard, though, because there are some kids that are oppositional and defiant. It's usually, though, when they're having their meltdowns, if it's autism. It's usually when there are little changes and they're freaking out, not that just, no, mommy, I'm not going to do it, that kind of stuff that Tara Mitchell is an expert in that. So anyway, this is kind of basically being able to approach people and socially interact. Deficits in nonverbal communication, things like eye contact, facial expressions, gestures are usually impaired. Prosody is our shrinky-dinky word for the rhythm of speech. Usually you have, with kids with autism, sometimes you'll have real flatness, monotone, like Ferris Bueller's Day Off, which probably none of the students have heard of. And then there's the rhythm, like Dr. Greg. That one's always fun, the rhythm. You get kind of specific rhythms and like a little lilt at the end. So anyhow, that's the nonverbal part. And then this one's basically they struggle with making friends and doing imaginative play. Bottom line there. For category B, you've got to have 2 of the 4, not all of the 4. Oh, and by the way, the new text, there's a DSM-5-TR, and the one thing it changes about autism is it just makes the category A, you have to have all of them. That part was unclear, and some people were not necessarily, you have to have impairment in all those areas, not just one. For these, you have to have impairment in 2 out of the 4, stereotypic motor movements, hand flapping, flicking fingers in front of the eyes, difficulty with changes in routine, like, when you drive home a different way, the kid gets super upset and starts having a tantrum. Highly fixated interest, one of my favorites. I get to see all sorts of interest. Ford F-150 trucks, dump trucks, roadblocks, Minecraft, cars, trains, all sorts of cool stuff. Unicorns, Girls tend to be more the animals, and the boys tend to be more mechanical. And then sensory input, that's sensitivity to noise, hating the toilet flushing, hating the hand dryers. I can totally relate to this. I cannot stand the little ticking in my hard drive on that desk. I cut it off and use the laptop. They can just be real sensitive to noise. I don't start to laugh. Okay, so let's see here. It causes clinically significant impairment in social, occupational, or other areas. All right, now to the test. This is that social communication questionnaire. I use this every time. 40-item questionnaire. You give it to the primary caregiver. I love it because it's carbon paper. Reminds me of the good old days. And so you get to tear it up, and I don't know, it's just some nostalgia there. And basically what it's done is it's pulled some of the key items from that extensive interview. And it has a cutoff score of 15. It's generally designed to be a screener. And so if you score above 15, then it's like, okay, you should get tested for autism. Frankly, I think it'd be great if it were used more often. I mean, it could be really helpful to determine whether or not a referral would be helpful for our clinic. I would love it if this was made available. Sorry, to more primary care providers. I think it could be super helpful, because if it's really low, then it probably is not really relevant, and they should probably go to a counselor or another psychologist. Jack Naglieri, University of Georgia graduate. I think he's now at UVA. He was at George Mason. He and Sam Goldstein developed the autism spectrum rating scales. These are really good. I personally don't use them much. I think Lori uses them a fair amount. The school uses them a lot, and they're good. They got two versions, 2 to 5-year-old and a 6 to 18-year-old, full length as parent and teacher items, and those are the scales right there. One thing, I don't believe they have a live scale, right? I don't think they have any of those like in the basque. I don't think there are any consistency or live scales, which I think would be nice, because you can get parents that, well, not necessarily for any malintent, but they can rate kids a certain way. You can see patterns of consistently negative, or they can be really inconsistent, and that questions the validity of the entire test. That would be my only criticism. I don't think they have them. This is that thing I mentioned earlier. I have it. I think I've done it once. I got trained in it a long time ago, and it's good. It's primarily used for research, and frankly, I don't think they've updated it in a long time. I think it's still using the old autistic spectrum disorder, where language and communication is one of the symptoms. But anyway, it's a complex algorithm, and but it's very effective and thorough as can be. Now, the ADOS, this is what we talk about. This is what people sometimes often refer to directly. It's given a ton of power these days. I'm not sure how I feel about it, to be honest. I mean, part of me loves it. Part of me is like, oh my goodness. When I say that, it's just like some insurance companies are literally requiring me to do this when we know a kid has autism. Dr. Panetta does, and all the other providers, and not necessarily Penn and her. They do an excellent job in identifying it in some of the early kids, but yet I've had several where insurance companies are requiring it, and it's not that I don't mind doing it, it's just the limited resources and other. I don't like to test kids unless they really need to be tested personally. That's just me. But anyway, that's aside. But it is considered the gold standard, and it's super cool. I mean, it really is cool though. It's super semi-structured, it is standardized, but it is standardized to an extent, but you can change the order of things. And the scoring, they don't use normal curves, normal scores, standard scores, sorry. This is just a picture of all the stuff that we have. I'm going to talk about it because hopefully this part will be interesting and fun. I'll talk about some of the key subtests, but you got like a baby doll. As you can see, it's pretty child friendly. You got this mechanical doll, which ours seems to only work half the time. You've got little pop-up toys, and some of the toys are obviously geared toward the little kids. Others are geared toward the older kids. So this is the picture of the kit. And there are 5 modules. It depends on your language level and maturity. Structured, unstructured activities, and you're really trying to pull for target behaviors. You're looking to see, does the child act like a typical child, or do they do specific behaviors? And I'll go through them with each one of these subtests. You're obviously looking at those criteria that I mentioned earlier. That's why it was maybe helpful to go over those. But eye contact, gestures, facial expressions, social interactions, social emotional reciprocity, and rapport, basically. That's a big part of it. And of course, you look for the unusual behaviors, and we see them a lot. Sometimes we don't, but it's not uncommon to see quite a bit. So the toddler module, Missy does this one. I've done it a handful of times. and I think I do okay. I guess I'll be honest, just personally, I get real nervous with the super itty bitties, particularly if they're global developmental delay, because you can have a lot of kids with developmental delays that have autistic features. And I know my bias is not, I'm more inclined, I think it's the beta error where you're going to say it's not autism when down the road, perhaps it may be, at least with the itty bitties. I don't want to say they have it and you're wrong. But that's just, I know that's my bias. Some people have the other bias. And anyway, not to get on a discussion there, but some of the toy, you get, some of the stuff is you get little toys out, you're playing with the kid. The blocking toy play is kind of fun. So you're playing with the kid and then you stop, allow, watch to see what the kid does. I mean, it's pretty cool that you can do these kind of things. And what do you think a kid does? I mean, they should get upset. And a typical kid will get upset and look toward the parent like, come on, man, why can't I play with the toy anymore, you know? And they're supposed to have joint attention and that kind of thing. Bubble play is awesome. You get a little bubble, you make bubbles, you blow them, and you look to see, does the kid go, oh, you know, and get real excited? I mean, that would be an extreme case, but we see that happen sometimes, you know, where the kid starts flapping. That often will pull for repetitive motor mannerisms. Or do they get excited, smile, look at the parent, look at the caregiver, and request for more bubbles? That would be a more healthier or a non, that's the typical response. Anticipation of routine with objects, that's really fun. You get a balloon, or I've got a little rocket thing, and you kind of, you go 1, 2, 3, and you shoot it, not in their face. You kind of, I mean, maybe a little bit. But you try to see, do they get scared? Do they, you know, what you want them to see is get excited, share enjoyment, and ask for it, you know? And that's what they'll do. The balloon, they can get excited. Now, sometimes you'll get kids that'll prompt them to do that if they have the flapping, because that's kind of a high stimulating activity, and they'll start flapping. Let's see, what are some other, when you smile at them, they smile back at you. Responsive, that's the responsive social smile. All the anticipation of a social routine is just peekaboo, you know, the peekaboo thing. You want to see if you try to do peekaboo with the kid, and if they won't do it, you ask the parent to do peekaboo. And there's a bath time thing. Oh, the functional symbolic integration one is where you've got a little a frog that you bounce a couple of times, and then you want the kid to bounce. And then you get a placeholder, which is just a block, and you bounce it once, and you want to see if they repeat that item. So that's the toddler one in a nutshell. Then module 1 is very similar to that. There's really not a whole lot different, except for the one at the bottom. Probably my all-time favorite is the birthday party. I love the birthday. I probably can't say birthday right. Birthday party. Whoops, probably should put that on quiet. So it's really cool. You got Play-Doh, you got a plate, you got a baby doll, and I love to sing, and I like to sing kind of loud. And if the kid has, you know, parents will say, oh, they're sensitive to noise, and if they don't, usually if they're sensitive to noise, they're going to cover their ears when I sing, because I do it moderately loud. But some kids, you know, they don't. And some kids get agitated about it and don't want to do it. But you're looking to see, do they get the routine? Do they understand the routine? Do they share enjoyment? Do they look at you? Do they smile? That kind of thing. I think it's a great task, and it's really fun. And I like to do the thing where I pretend to feed them. That's always kind of fun. You know, like you put the food on the fork and kind of open up, you know, and you usually can get a response there. Particularly if they're a little bit older, they get annoyed by it. So that one's kind of fun to do. Oh, Lord, don't turn me into the board after this talk. Okay, module 2, this is one I do. The 3, I do 90% of the time I do module 3 because I get the older kids, but this one I get sometimes. This is for kids with phrase speech. The other one was just like single words, and toddler was even no words. But this one's where they have phrase speech, but not fully verbal. Construction task, it changes a lot here. You get like a little puzzle, and then you put the puzzle together, and you watch the kid put the puzzle together, basically. Response to name is the same as the other one. You say their name, and you expect them to just look at you. That gives you the 0. I'll get to the scoring at the end. 0 is if they do what they're supposed to do. 1 is if they partially do, and 2 is if they really don't do what you expect them to do. There's the conversation press, where you really try to have a joint conversation with them. I mean, it's hard in module 2, and so they don't have to do a whole lot, but you look for a conversation. And make-believe and joint interactive play. These are huge. These are where you put a ton of toys on the table. I've got action figures, I've got holographic disc, a little wrench, a little pliers. What else do I have? Gosh, all sorts of stuff. Little food items. And you just put them out there and say, I'd like to see you play. You know, and it's not uncommon for kids on the spectrum to just look at you like, you're going to do this. I don't play, man. You know, you don't. And they just don't. They're not into it. But what you typically see, a typical kid's going to have them get the action figures and fight and beat each other up and maybe throw stuff on the ground. A really aggressive one might take it to a different level. But that's the kind of stuff that you tend to see there. And then, you know, some of the behavior, like when the kids, you know, if they start grabbing the pliers and sticking little toys in a cup, it's just kind of weird play. If I had to pick one behavior that I think I later will make a diagnosis, it's probably that one. Most of the kids that do that extensively tend to go on getting a diagnosis, it seems to me. That's just my personal experience. Let's see, what are some other ones? You show them a picture and you ask them to talk about it. And that's where I get for reciprocity, because I have a map of the United States and I'll say stuff like, I lived in Texas for a year, my daughter lives in New York, my son lives in Utah, and they're like, okay, so what? You know, in Minecraft, you can do blah, 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 blah. You know, I mean, I get that a fair amount. Or they just dead flat, don't know how to respond to those kind of statements. The birthday party's on there. I think some of the other stuff is pretty much on there. Cartoons is not on this one. Cartoons is on module 3. Cartoons is fun. That was number 7. And you really don't have to do them in this order. I don't really know why I numbered them. I guess technically that's probably how they're listed in the manual, the protocol. But yeah, the cartoons, it's there's 6 cartoon cards that tell a story, and then you ask the child you take them away, and then you ask them to repeat the story. And so it's a funny story where the monkey's climbing up a tree, throwing a coconut down, another monkey takes it, you know, the first monkey's confused, monkey comes back, the monkey in the top sees him, says, you're not getting my coconut this time, and whacks him on the head. You know, it's basically that. Now, I'm using a lot of gestures. I had a kid the other day crack me up. He started cursing when he was going through it. I just loved it. It was so much fun. It was so much fun. And I won't say what he said because I guess it was unprofessional. But it was so much fun. Oh my God. He was like, and he ain't getting well, I won't say. But I loved it. I have to say that one made my day, made my week. Let's see, what else? I think I've done most of these on here. Emotions, though. Here's where you start. It's way more verbal, though. You ask them about emotions, what makes them happy, what makes them sad. You know, sometimes I don't have the parents observe. I didn't say that. We often have observers. I sometimes won't have the patients observe with the older kids if I think they're not going to talk about the stuff. You know, particularly social difficulties, annoyances while they don't have relationships. That kind of thing. You ask them about friends, marriage, relationships. That's a fun one. I had a good answer on that one the other day. What was it? So people get married so they can do inappropriate things together. I love that answer. I had another good answer there. That one was fun. Yeah, so I do a lot of it, but you get some fun answers. 4, I don't use it too much. It's mostly for adults. And it's a lot of interview stuff. I won't really belabor this, and I'm probably talking too slow. But basically, it's a lot more interview stuff on the right-hand side. Daily living, hopes and plans, the future, that kind of stuff. All right, I already talked about the scoring. And then bottom line is you don't get standard scores like on an IQ test, like a 50 or an 80 or whatever. You know, you basically get a minimal to no evidence, low, moderate, and high. Occasionally, you'll see a report that's done that lists the actual, you know, the 0s and 1s and the 2s, but Kathy Lord made it crystal clear in the manual that you're not supposed to report those. So you won't see those from me. Definitely consider just a tool. It's one thing. Sometimes kids have awful days and they won't even cooperate and I can't get anything out of it. So it's helpful, but it's not the be-all, end-all. Now I'll switch to intellectual disability, and good Lord, that's too much text, I know. But basically with intellectual, this is the DSM. I'll let y'all look at it if you want. The bottom line is you're looking at 2 things. You're looking at intellectual functioning and adaptive functioning. They have to really struggle significantly with their intellectual functioning, which typically means their IQ is 70 and below. 100 is an average IQ. 70 puts you at the 2nd percentile. Because of standard error of measurement, you can go up to 75. So there are a lot of kids that I diagnose between 70 and 75 if they have a significant deficit in adaptive functioning, which I think is the next slide. Oh, no, that's the normal curve. Yeah, when I'm talking about the numbers, you can see, 90 to 109 is average. You all know this stuff. But bottom line is 70 and below is typically an intellectual disability. I'll go up to 75 because of error measurement. And the DSM makes it crystal clear that you can do it that way. But then the adaptive functioning, the way the DSM breaks it into conceptual, social, and practical. Conceptual is basically language and learning. Social is social. You don't need to belabor it, but I mean, there are some, I think I have one more slide that details the social stuff. And then practical, which is daily living, toilet training. Can you put your clothes up? Do you not touch hot things like the stove or an open fire? That kind of thing. It does occur during the developmental period. I mean, if you get somebody coming in late that's all of a sudden had significant deterioration in cognitive functioning, it's going to be something else. So yeah, there's the more thorough stuff about conceptual. I guess it's reading, writing, social is awareness of thoughts, feelings, experiences, empathy, interpersonal communication, friendship, social judgment. And of course, when I'm testing kids with autism, that should inherently always be really low when I do the Vineland. And the way you assess it, the serious severity levels, sorry, I'm jumping ahead. Most of the kids we see are mild, 85% are mild, moderate is about 10, severe 3.5, profound 1.5. Unspecified, I get it at least probably twice a month. Those are kids that I can't test. They're extraordinarily impaired. I have to test them because of the developmental disability waiver. They come in, they're super upset. They might start banging their head, or they might start biting their arm, or they might just shut their head down. They usually are screaming their heads off. And I try for maybe 10, 15 minutes. It all depends. Sometimes I've gone longer. But when they clearly are so upset that there's no way I'm getting anything, I stop it, do the Vineland, and I give that code unspecified intellectual disability. Of course, things that are associated with ID are difficulties in social judgment, problems with school, work, gullibility, easily exploitable. They can unintentionally be involved in crime and stuff. This slide was here. This is an important point with our assessment. 35% of the kids with autism do have intellectual disabilities. And so it's not necessarily an either or thing. Some people think it's either ID or autism. It is very complicated, though, when you have the kids with intellectual disability, because sometimes they can have a few features but not meet the full criteria. But 35.2% do meet the full criteria. When I started here in the early 2000s, we were saying 75%. I think we basically weren't getting the high-functioning kids as much. Now we go to intelligence, just a brief. I'm okay. Just because I think it's fun and I like documentaries and history is cool. Before I go over the IQ test up here, these are some of the key developers. Really, I just go over the two main ones. Alfred Binet, who was a French psychologist, did the first IQ test, the Binet-Simon, and it was really to identify kids who needed more help in remediation. He teamed up with this dude, Louis Terman at Stanford, and then that's how it became the Stanford Binet. Wester's the guy on the upper right. He's a Romanian-American psychologist. He developed the Wester scales. There's, I think it's the WIS-4 and the WIS-5. And Wester has the famous quote that intelligence is the global capacity to act purposefully, to think rationally, and deal effectively with one's environment. I like that. I mean, there are multiple definitions, and then you have the emotional intelligence. I mean, that's a whole other talk, really, but I kind of hit those, at least those key people right there. So cognitive measures, I'd use the DOS all the time. I think we have the DOS, we have the WIPSI, and we have the WISC. You don't do the Stanford Binet, do you? I don't think we have that. Frankly, I hardly ever see that one ever used. I mean, I've hardly ever seen it used. Now, the Kaufman is used. That's another Georgia guy from the school psych program. That's who Naglieri trained under. But anyway, he developed the Kaufman assessment battery, and I'm seeing that more and more from school reports, a fair amount. So nonverbal measures, and I'll hit some of these in detail. Lighter, Western nonverbal. Naglieri is one of the authors of that, and I like it, except that there's a coding task, and most of the kids I see have really bad motor skills, and so I feel like that nails them. You can prorate it, but then I just don't think it's as robust when you do that. We have the Bailey. Dr. Panetta's used it was it just research, right? Yeah, I think she had a research thing going on. We don't routinely do it, but we do have it. So this is the DOS. This is the IQ test I do. You got early years level, school years level. You get two main composite scores, general conceptual ability and special nonverbal composite. It's really cool that we have the special nonverbal because sometimes you don't realize that the kid's going to struggle greatly in language, and there may be a severe deficit between their verbal and their nonverbal. And when that happens, I can use that composite as an overall measure of cognitive functioning. There's 6 subtests for the standard battery. And you wouldn't, so the first 2 are really for the early years, like for the little kids. This is the verbal ability cluster on the left. Verbal comprehension is cool. You start with these little wood pieces, and you ask the kid to do stuff with them, like put it behind the back. I think that's pretty tricky, like, while you touch the tree, hand me the truck. You know, it gets kind of hard. And then the next part is you have a picture that's got a scene, and basically just read a story. And they have 5 pictures, sorry, and they got to point to the picture that goes with the story. Naming vocabulary is just naming, a picture, you name what the thing is. That's really for the early years. For the older kids, word definitions, they define words, and then verbal similarities, it gets pretty complicated. You say 3 words to them and you ask them how they are alike or the same. For nonverbal reasoning, you've got picture similarities, where you match like a picture, maybe you'll have a bottle and that goes with the baby. And it gets progressively harder. Matrices is a classic nonverbal task. I think it's the main part. There's another nonverbal test I didn't put on there. I think it's, I'm drawing a blank on the name of it. But anyway, you got like 4 squares. 1 square is empty. You got 5 choices at the bottom. Simplest example would be like X, 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 blank. And you'll have like circle, period, X. Well, obviously the X completes the pattern. And they get progressively way more complicated. And then sequential and quantitative reasoning. For the younger ones, you have pictures, and there's a picture missing. Go ahead.
Sorry, just for the naming vocabulary, are there equivalents for other languages and multiple languages, or how do we assess international kids?
I usually do the nonverbal if they don't speak English. Yeah, there are Spanish-speaking versions for some tests, and I'm not sure if there is one for the DOS. There is for the Wessler, I believe. Is that right, Lori? I think there is.
I think there is for the Wexler. I think you're right.
Yeah, but if I have a kid that I know, but I guess maybe are you talking more like a cultural thing?
Yeah, a little bit, like parents aren't from here, and so maybe their first language is not English, and maybe that's not taught at home, it's hard to assess verbal.
Then I'm probably going to use the lighter international performance scale, which is a nonverbal, if their language is low. But if the kid is like, say they're 7 years old and they've been in the American school system, I'm still going to do this because they've been exposed. And the stuff in there is pretty universal stuff, like a bottle, a pen. I mean, they're really objects. But I guess you could argue, I mean, the verbal ones, that is an argument, or they're not as cultural fair. I mean, clearly the nonverbal tasks are cultural fair because they take out the language piece altogether. I think that was a pretty decent answer. Spatial, let's see here. Spatial is like, this would not be verbal either, but you get some motor skill deficits on that one. Like where they have to, there's a pattern construction where you got blocks and you got a picture, you got to match the blocks to look like the picture. And then copying, that would be my downfall for sure. You just have to, for the little kids, they just have to copy a shape. And then recall designs is hard. You show them a shape for 5 seconds, take it away, and they got to draw it. So that's pretty rough. But some kids nail it. And then the Wessler, Lori uses this one a lot more. I used to use it all the time, but I just found the DOS is a little quicker, a little more kid-friendly, and I've just been using it forever. But it's an excellent test. As you can see, it's pretty similar. I won't really belabor. I mean, the subtests are very similar. You do have this figure weights thing where you try to balance something on the fluid reasoning, but they still have the matrix reasoning task. Block design is using blocks. They do puzzles. They put puzzles together. That's pretty cool. Now, they do have working memory and processing speed. That's when those load into the overall general full-scale IQ. But there is a general ability index where you take those out. But you do have these in the WISP where you have digit span. You read a series of numbers and have to repeat them back to you in order. I would not want to do that one these days. And then processing speed where you're coding tasks and you're being timed. And then a symbol search. It's really looking at your psychomotor speed. And so, these are already talked about general ability. It does give you a nonverbal, cognitive proficiency. I mean, it's great. It's a great test. And then we talked about the LIDAR briefly, so they're the 4 subtests. The first one is where I've got a card, and it's got a picture, and the child has to point to where it is in the background. Like there's a picture back here. Gosh, maybe I should have brought some stuff. I probably should have done that. If I do it again, I'll do that. Form completion, but then nobody can see it from back there, is you get a jumbled up card, and you have to point to where it's put together. So it's really a form completion, a visual closure task. The first one's really visual scanning, visual processing. And the next one is classifications. These bottom 2 are more reasoning tasks, where you have to sort how things go together. And then sequential order is how you look at how things are sequenced together. All right. We already talked about the list of some of the adaptive functioning tests. Let's see, the Vineland. You always interview the parent when you do that. And we already talked about some of the key things you're looking for. These are basically the domains. You've got communication, which has receptive, expressive, and written language, daily living skills, personal, domestic, and community. Socialization has those subscales, and then motor skills. I won't belabor that. Developmental disability waiver. I don't even know if I don't know why I put this in there, but one of the reasons why I mentioned earlier, one of my roles is to do, and that really is just specifically testing more than assessment, because you already know the kid has autism. I'm just specifically testing for their IQ. And so there's building independence, family individual supports, and community living. Basically, these are to help people get services, typically when they get older. Kids that have autism or severe developmental delays. It's a great program. There's a long wait list, typically 8 years. But you can get employment and day services, residential options, crisis supports, and additional services like technology, electric home-based services, transition services. It's really super helpful. A lot of our kids end up needing that. Let's see, specific learning disability. I'm doing pretty good here. That's where we're looking at slow reading, slow learning, slow spelling, difficulties with written language, mastering number sense, and difficulty with mathematical reasoning. Oh yeah, this is a request, and I don't know, I don't get in trouble for it, but I get a lot of referrals for kids that have already been tested, have an IEP, and are getting services. And I really can't, there's nothing I can do to help those kids. Because we don't do tutoring, we don't do interventions in our clinic, we just do assessments. So when I've been charged to review all the older referrals that come to me, if that's one, I'm usually probably going to turn it down unless I can see a reason, like perhaps they disagree with the testing or something. But if a kid's already connected, you know, they really need to go to a tutor or a place that provides intervention versus assessment. Woodcock-Johnson is the cognitive achievement test that I use the most. And this is where you're looking at reading, writing, math calculation skills, broad written language, and written expression. And so you have tasks where you, for the reading ones, where you're like reading words, you have to read a passage and find the word that's missing. Fake words, word attack, as they're called pseudo words. Oral readings where you have to read a passage. That one's hard because your scoring is very tricky. If they hesitate, if they insert, if they omit, if they substitute. Of course, mispronouncing is the most common error. So that one is kind of tricky to score. And then sentence reading fluency, where they have to read simple sentences and answer yes or no. For math, you got basic calculation. You got to do simple math problems in a 3-minute period and see how many you can do, and then word problems. And let's see, I think I did that. So ADHD, I guess, oh, that's good, yeah. I'm not going to really go over this stuff, but there's inattentive, hyperactive, impulsive, unspecified. I won't read all these. I'm sure everybody knows the criteria for ADHD, but there's inattention, distractibility. With the inattentive type, you don't have the hyperactive and impulsive symptoms. You have just these inattention, difficulty with organization, avoiding likes and dislikes, losing things, getting distracted. Hyper, fidget, squirming, run around, on the go, talk successfully, bursts out answers to questions, difficulty waiting the turn, those kind of things. The thing that I use, and I'll tell you since the COVID, not to sound negative, but I've had the hardest time getting schools to return these to me. Honestly, I've done very little ADHD assessments. I had one yesterday. I have one teacher turn it in. I have to have at least one. But the test itself is excellent. I love the test. It was designed by Cecil Reynolds, also at University of Georgia. I guess maybe there was a bias for Georgia in that thing. But I did pick that one over the Connors, probably because I was exposed to it a lot at University of Georgia. The school psych department was downstairs from the counseling site. And so anyway, Cecil Reynolds designed this. It's a great test. It's a broad-based behavioral, lots of, here, I'll just show you the scales. And it uses T-scales where 50 is the norm. 60 to 70 is at risk, 70 or above is higher. And so you've got broad-based scores, externalizing, internalizing, behavioral symptoms index, and adaptive skills. And then you got the problem scales. And so what I like about this too, it has validity scales. I don't think I have a slide on that. It measures consistency. It measures if they're excessively negative. And I think those are the main ones. And so you can know whether or not some people just go XO, XO. I mean, hopefully parents aren't doing this on their kids, but sometimes you can definitely see some patterns. And some of them are real inconsistent. They ask a lot of the same questions. And if you get extremely inconsistent answers to the same question, it's like, okay, what's going on? You shouldn't have inconsistent answers to the same questions. But the problem scales are hyperactivity, aggression, conduct, anxiety, depression, somatization, attention, atypicality, and withdrawal. Another reason why I like doing this instead of just a single, there's a great test. It's the Connors. It's strictly a ADHD rating scale, and it's fine. The thing I like about this, though, is all the items are mixed up, so you don't get in some response pattern where they're just saying, oh, yeah. So you got a whole, that's another reason why I like it, even though it's more cumbersome. But it also can reveal other stuff, like anxiety can often easily be mixed and confused for ADHD. Depression could be going on, and you might not know it, that kind of thing. And it does have adaptive scales. Their adaptability, social skills, leadership, functional communication, activities of daily living. And the computer test, we're almost done, is the younger version is KCP2, which is 7 and below, and then the CPT3, which is 8 and above. And it's a pretty cool test. I've worked with two. I used to use a TOVA in the past, but basically you have letters that pop on the screen one at a time, and you hit the button for every letter except for X. And it goes on for about 15 minutes. Honestly, it's hard. I took it in the beginning just to see where I scored. And so anyway, it's hard to do, and the kids, it can be challenging. It's not perfect. Some kids can do well on it that still have ADHD, but it's consistent, and so I kind of use it as like a tiebreaker. And I think this is the last slide. I know you're exhausted. For inattentiveness, basically, and this is a heavy slide. This is basically this is what the kind of the outcomes for the computer test. It's pretty cool though. For inattentiveness, like if you omit a lot of the targets, if you make a lot of commission errors, if your response speed is typically it's slow when you have inattentiveness, and variability. If you're not consistent, your response that kicks up the inattentiveness. Impulsivity, usually if you've got a very high, very fast. Some kids are super fast. They usually make a ton of commission errors because their goal is to get as many as they can, so they click the X a lot of times. And they also are going to have high perseveration errors, and that's where basically you can hit the button before physiologically you've had time to process the response. When that happens, I mean, it's not physical to actually process it. It's usually you're either really slow and inattentive from the previous item, or you're that anticipatory response with impulsivity. And then you have some sustained attention, which is basically over the blocks. It measures over the blocks of time. Those are what those bottom two. It's kind of like, are they able to maintain focus over the extended period of the test? And I think that's about it, y'all. Oh my gosh, you'll love my questions. Simple. I don't know how to do this slide. Do I have to say these out loud? Okay. What test for autistic spectrum disorder is considered the gold standard? The Wechsler Intelligence Scale for Children, the Connors Continuous Performance Scale 3rd edition, or the Autism Diagnostic Observation Schedule 2nd edition?
C.
Yes. Y'all are paying attention. The next one. Which of the following are assessed at the Child Development Clinic? Severe head injuries with memory impairment,
Yes.
significant learning problems, intellectual disabilities, autistic spectrum disorder, or my favorite, I had a grad teacher that did this. She tried to ding us. She would give us like B, C, and D. B, C, and not D anyway. But this one's pretty obvious. B, C, and D. So what's the answer? It is E. We do not do severe head injuries. And honestly, Alan Katz is the only neuropsych that I know of, and I've heard that he's retiring. We had a person named Ann Solinger here that used to do neuropsych with kids, but I don't think there was enough business for her. So I don't really know what we do. I guess we send them up to UVA is what we're going to have to do, I'm afraid. I think there is going to be a paucity of people doing that. I should probably do my research to make sure there's not anybody that I don't know of. I am pretty active in the local psych association, but I don't know of anybody else. How long did I take? It's all right. That's 50, right?
Yeah.
That's a lot of work. It's informative and somewhat entertaining. I don't know. Y'all got any questions? That was a good one about the nonverbal there. I like that.
I'll have a comment about, it's kind of similar, like talking about cultural biases in testing and things.
Oh, yeah.
You know, these tests do try to minimize that, but it's impossible. And I grew up in a further southwest from here, in a pretty rural area. And one of the IQ questions is, this is one of my favorite answers I remember. It's actually one of my friend's kids. What are the 4 seasons? And his little boy, and he said, well, there's hunting season, fishing season, muzzleloading season, and then another one which was a little different, but still pretty cute. He got pretty far in the, you have to define some words, and I said, what does migrate mean? You know, and he said, like my great big truck. So those are just my favorite. Like I just remember somebody, like Greg said, you get some really fun answers. Yeah.
Does that count?
Yeah. Unfortunately, it doesn't. But, you know, what were you going to say, Dr. Pershar?
You probably queried him on that, though, right?
With the seasons.
With the seasons.
I asked somebody that once, and they said, you mean like the Four Seasons Hotel?
Oh, different culture. Yeah.
Doctor,
Yeah.
did they change the criteria a little bit for ADHD? Like, does it have to be 6 and above?
That's what, as far as I know, I haven't looked at the brand new one. I believe it's 6 or more for each. So 6 or more for the inattentive and less than 6 for the inattentive. 6 or more for the hyperactive impulsive and less than 6 for the hyperactive impulsive, and then 6 or more for both of the combined. You know, now you have that unspecified one. I don't hardly ever use it. I feel like it's kind of, I mean, you can use it. Do you ever use it, Allison?
I only use it when somebody comes in from from the PCP and it isn't differentiated, because by then they're on medication and the parents are not rating them based on how the symptoms were before, and so that's the only time I use it.
Because it feels kind of like, I don't know. I don't really ever use that one.
So I have a couple kids who come in at like the age of like between 13 and like 17.
Yeah.
And they want to be evaluated for ADHD or ADD. Really, their parents are like, they need to be evaluated. And I know typically that would present younger. How do you approach that? Is it, yeah.
Well, it's a good question. And when I was at Lewis Carroll Clinic, that was a big part of what I did. I did a lot of ADHD testing on kids just like that. And it can happen if you have really bright kids that are kind of, you know, they're really, really bright. You know, they maybe not working too hard, maybe not. That was always the question. Is it motivation or is it really ADHD? A lot of times they weren't really putting in the effort. But sometimes they really did have ADHD, and it's just that they were so high functioning in the early years they could get by.
Yeah.
But then once they hit the harder, when the school got really hard, then it's like, oh my gosh, I can't focus.
Right.
And then some of those really truly have it. So you would do a workup, you know,
Okay.
you would do the rating scales, computer measure, interview. I used to, when I was at Lewis Carroll, I always did an IQ test, and I did the WIS to see if the working memory and processing speed were lower. I don't really know that that's considered standard anymore. I think most people just use the rating scales and maybe a continuous performance measure. But it's a valid reason to get tested. I mean, that's yeah.
Thank you.
This is not as much as a question as a help me, please. So what I'm noticing in the clinic is that post-COVID, that we had all that, you know, we weren't seeing patients. So I'm seeing older kids who are starting school, who are now presenting with major issues in school that do not already have a diagnosis that you would expect a little earlier, like the autism spectrum. And they're getting into lots of trouble. The school is having a hard time. The parents are at their wits' end. And it's more than I expect for this age group. What is the best way to handle it? Because my lagged wait time is so long. I'm not sure where to send people to. How do I get them tested? What's the best way?
Like what kind of, it's hard because some of it's really tricky because is it that they're behavioral and just kind of refusing to do the work
No, this
or?
is more suspected like autism
Oh,
or
autism.
intellectual deficiency, but mostly suspected autism in an age group where I would have thought that we would have picked it up before, but we didn't see kids routinely for up to 2 to 3 years.
There's a 2 to 3 year pause.
Yeah.
Yeah, oh, that's interesting, yeah. I mean, I've definitely had an uptick. I found a lot of those have social anxiety disorder. I'm getting a ton. That's always, I mean, with those, that's what I would always wonder. I mean, I've had, oh my gosh, it seems like on Wednesday I do the intakes. It seems like at least one of them, that's what they have. I've seen a huge uptake in anxiety. I don't know if it's probably, I mean, if it was autism, it should have been detected earlier in you said 14-year-olds?
Like 5-year-olds.
Oh, 5-year-olds. Oh, well then, yeah, that is hard. It very well could be, because, yeah, they haven't been in school. And what's hard, too, is, yeah, they hadn't been in school, so have they had the opportunity to learn the skills? It's super hard. It's really hard, because then they've been underexposed, I guess. Yeah, I don't really know that I have an answer for what to do, but I mean, it's,
Who do I send them to for the easiest way? Does the school do the evaluations? Do I send them to behavioral health? Do I send them to you?
I'll let my colleagues say, because I do the younger ones more than me. What would you say?
The school, if they're having issues in school and it's impacting their education, the school should be doing the evaluations.
Sometimes getting their engagement is tough too, I'm sure, Dr. Burbage.
That is a good point with the school stuff, like even, and I probably should have had a slide on that educational. I mean, I can say a kid has a learning disability, or I can say they have autism, and the school might say, well, that's fine and dandy, you went up there, but we're going to do our own testing. Legally, they can do it. And they don't even have to accept mine. So that's a good reason why it is helpful to go straight to the school. And then if they reject them, then it can be pretty helpful if there seemed to be enough evidence for maybe autism that they missed. I don't know, hopefully that helps.
Comment on the previous question on the older kids with ADHD. I've always been frustrated by those, but I think now, I don't know if it's just pandemic. I think a lot of this is coming without a pandemic. The pandemic may just change the shift. But I certainly, I see a lot of folks come in, they say, my kids can't pay attention, and you really get down to it. They're depressed as heck.
You're right.
More the social anxiety piece,
Yes.
and so it's, routinely now, I mean, a lot of times in the outpatient world, we use a lot of the Vanderbilt forms. Those who haven't done the REACH program, I have not, but I know it's the value of it is phenomenal, and the folks that have done it taught me to use like the PSC 17, some of these other rating scales, that's off topic for what you're telling us.
No, it's
Wow,
good. It's relevant. You're right. I mean, the pandemic nailed a lot of kids, got a lot of depression and substance abuse. I can't remember the stats. I've read some, but overdoses have gone off the charts. I think the past year. I wish I could remember the stat, but it was a lot.
Thanks, Greg.
Yeah.
Yeah.
Thank you.